This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host, and today I'm sharing my conversation with Mick Hughes about ACL injury management. We discuss key factors in choosing surgical versus non-surgical management, including pros and cons, what effective prehab and early post-op rehab should include, how to safely progress exercises in the post-op phase, when to safely introduce open chain, knee extensions, running, and plyometrics, common mistakes clinicians should avoid in ACL rehab, return to sport guidelines, and more. Mick is an APA title sports and exercise physiotherapist and co-founder of Learn.Physio. Now based in Townsville, Queensland, he consults at the North Queensland Physiotherapy Centre with a strong clinical focus on ACL injury prevention and rehabilitation. Mick co-developed the Melbourne ACL Rehabilitation Guide and is actively involved in ACL research, teaching, and mentoring students across several Australian universities. If you find our conversation informative, I encourage you to subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share this episode with your colleagues in the clinical field who could benefit from these insights. Thank you for tuning in, and let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like
Welcome to Urban Polling. Discover the Activator program and polls for rehab and balance.
Neck Care.
Treating neck impairment? Get objective neck assessments with the Neck Care system. Learn more at neckcare.com.
Hi Mick, welcome to PT Pro Talk. How are you today?
Very well, Mariana. Thanks very much for the invitation to come and talk. I'm looking forward to the discussion.
Awesome. So let's get started talking a little bit about yourself and your background, your career, for the ones that don't know you yet.
Okay, yeah, sure. So I'm a physiotherapist or a physical therapist for those that are listening in the US. I've been practicing for 15 years now, and in the last 5 to 7 years in particular, I've specialised and have done some postgraduate training to be able to call myself a sports physical therapist or a sports physiotherapist. In Australia, I'm not sure what it's like in different regions of the world, but to be able to call yourself here in Australia a sports physiotherapist, you have to undertake some postgraduate training or a master's degree. So yeah, that was something I completed just before COVID hit in 2019. So yeah, I've sort of got to that stage in my career where I actually can call myself a sports physiotherapist, and I've been doing that for quite some time. And during that time also too, that was kind of the peak time where I really developed a strong interest in managing ACL injuries and helping people through their recovery. So yeah, I've been specialising in looking after a high volume of ACL injuries for the last seven years or so. Prior to that, I completed a degree in my early 20s being exercise science, knowing that I really wanted to go down the pathway of being a physiotherapist at one stage in my life. I was just never that diligent in high school to get the marks required to be a physiotherapist straight from high school. So I took the long road, but upon reflection, it was a necessary road to take. I firmly believe that having a strong understanding of exercise rehabilitation is an important skill in being a physiotherapist, and there's probably not enough time, unfortunately, to develop those skills in the undergraduate degrees that we have. So that certainly has helped me be a better physiotherapist in the long run. So yeah, that's kind of me in a very brief nutshell without taking up too much time of your listeners' ears. So yeah, that's where we are.
Before we continue our conversation, I wanted to take a quick moment to tell you about a special offer from Sarah Health. Visit sarahealth.com/ptprotalk for a 90-day free trial. That's sarahealth.com/ptprotalk. Make RTM simple. Choose Sarah Health. That's sarahealth.com/ptprotalk. And now let's get back to our conversation. And so I wanted to start discussing with you about ACL. So first, let's say the patients come to you, they had an injury. Are they already with their MRIs diagnosed with ACL injury, or do you help them on that process between choosing surgery, no surgery? So how does it work when you start screening a patient?
Yeah, it's a really interesting question. It's a really tough one to take, but it's a really important part that we actually do play an active role, and I do play an active role in the discussion about what happens next for the individual, because often the individual that tears their ACL, probably from the moment that they injure their ACL and their knee, there's an overlying message that often says this person needs surgery, and that's going to be the outcome for this individual. And we now know with greater confidence that surgery is not the only option. So I see myself as the voice to shine a light on rehabilitation. And now, look, this person still may desire surgery, and that's fine, or they are a person involved in high-risk sports where the pivoting, twisting nature of sports, be it soccer, basketball, volleyball, rugby, football, whichever sport where there's lots of pivoting, twisting, turning, changing of direction, where the knee requires some degree of stability. Now, some may argue that people can go back to sport, those sports without an ACL, and that's true. I've seen it many, many times. But I've also seen the catastrophic events that occur when people go back to those sports without an ACL. So the evidence is pretty unclear, and it's almost like a toss of the coin about who is successful and who's not. But I firmly agree, at least there should be a period of rehabilitation and some progressive rehabilitation to see if this person can keep pursuing this treatment plan. So I like to sort of get on my high horse and say, let's talk about rehabilitation. Let's talk about something other than just surgery and guaranteeing these people a pathway of surgery. And I'll talk about the current evidence that says 50% of people can go back to pre-injury levels of sport without an ACL and have a great outcome at 2 years, 5 years, 10 years down the track. So that's certainly a breath of fresh air from what I've seen with people, because often they hear surgery from the first person they meet. They'll often see a doctor who will also talk about surgery. They'll see a surgeon who also talks about surgery. So for them to come to see me and have that different discussion, I think it's quite empowering for the person to see all of a sudden they've got a choice. So we talk about that. And we also, too, due to some recent emerging evidence, sometimes discuss the role of potentially bracing the person. There's some emerging evidence that a bracing protocol can assist in the ACL healing. So we have that discussion as well, which is certainly probably a podcast in itself. But we do flag the cross-bracing protocol, and I certainly do discuss the cross-bracing protocol as an option if they're a suitable person to go down that path. And my role certainly is to provide some options other than surgery. I think the compounding issue here is the person that and who, I guess, the condition that sort of trumps all these desires to continue going down a rehab pathway or continuing just conservative management is the person that's got a locked knee, where surgical intervention is probably the best course of action for this person. If they've got a bucket handle tear of the meniscus, for example, or they may have a pretty decent chondral lesion, maybe a piece of their cartilage had sort of maybe chipped off and broken off, and probably helps this person in the long run if they have that piece of cartilage put back in place, if it can be salvaged, or if there's a fracture. Lots of different reasons why someone may need to unfortunately have early surgical intervention rather than trying a period of rehabilitation. So that would be the only caveat there is, no matter how much we sort of like to give people choice and options, there'll be a small percentage of a rather small percentage of the person in the population that will unfortunately have to go down a surgical pathway. But the vast majority of people, we should be having that discussion. I certainly have that discussion about rehabilitation.
Mm-hmm. And then the ones that already saw a surgeon and they are kind of decided to have the surgery, do you see them changing their minds often, or is that something that's harder in general?
No, to be honest, I think when someone's already seen the surgeon, they've kind of already had their mind up. They might have their own personal preference, and that's fine. There may have been some people before going in to see the surgeon and visit the surgeon that may have been sort of sitting on the fence, and they still may very well be sitting on the fence. It's just no one's really brought to their attention the option of rehab. But most people that I consult with who have injured their ACL, has seen a general physician or a general practice doctor, has then gone to visit the surgeon. They've heard surgery. They may have already had some friends who have gone down the pathway, or some athlete friends or some colleagues or family members who have all unfortunately injured their ACL. So they're kind of already mentally aware of what the process is, and they may have some firm beliefs about what happens next, and that's fine. My role is not to necessarily rock the boat, but also just to discuss there are other options. If they're not willing to learn, my job's not there to try and make them change their mind. My job there is to assist them in improving the knee health of their knee prior to that surgical intervention being done, and making sure if that's what they want to do and if that's the decision they've made, my role is to make sure that knee is as happy and as calm and as strong as possible prior to that person having surgery, and also to gathering some preoperative outcome measures that I'll be using at a later date to help make better return to sport decisions as well. So, that's kind of where I see my role.
Mm-hmm. And is there a way that you screen these patients to see who would be a good candidate for like a non-operative ACL? Or is it like, do you just prehab everybody and then if they respond well, they might not do the surgery? How does it work? Can you know in advance?
Yes and no. We used to use and some people still do, and there's nothing wrong if you still use the COPA classification system, where you'll use 4 different screening tools in the clinic to decide on whether or not someone is a potential COPA or a potential non-COPA. So those decision tools are 2 patient-reported questionnaires where you ask the person their global rating of knee health, and they'll score that from 0 to 100. You'll do a global knee score where you ask the person, a COS, it's a knee outcome measure. So that's a score where 0 to 100 is the outcome, and we're looking for a score over 80. Then we do a series of single leg hop tests. One in particular seems to be more valuable, being the 6 metre timed hop test, and we're looking for an 80% limb symmetry score. And the other thing to understand is, has this person only experienced one instability episode, being the injury? So if the person scores above 60, they score above 80 on the COS score. If they score above an 80% limb symmetry score and they've had no further instability after the injury, they're actually identified as a potential COPA. And they can and should be offered non-operative management. And then the decision to progress through is guided by the person, how their knee responds to further strength training, further time, and then progressively through running, jumping, changing of direction, unplanned movements, reactive movements, and you're kind of walking their way back to potentially playing sport again via the same process as you'd take someone through if they've had a reconstruction. And then, if these guys and girls are being successful, then they pass the same return to sport measures as we'd have someone do if they had a reconstruction. The only problem with that is twofold. For someone who initially doesn't pass those 4 criteria, are often labelled a non-COPA and often recommended surgery. And we know this is quite a fluid, like these numbers and these tests are not set in stone. You can be a potential non-coper week 3 post-op, but give yourself another another 4 weeks or a month of rehab. You can change. You can change your coping status to go from being a potential non-coper to being a potential coper. So it does sort of wax and wane, and it does have the ability to change in the matter of a day. So it is a hard one to use, and it's not a great one to use, if I'm being honest, and I've certainly shied away from using it. But rather, I basically I have that discussion with the person. The only decision really for me is, do they have the repairable things that surgical intervention is urgently required, or do they have a time-based goal? Someone who's a professional athlete who's getting paid by the day, by the month, and that every day matters, every week matters. These kind of people, unfortunately, are in a situation where, for planning and contracts and the bigger beast of what professional sport is, surgical intervention is often done in a more timely fashion for these individuals. But people who aren't getting paid to train or play their sport, then they arguably have the luxury of time, and time is on their side. So I tend not to use the COPA classification system anymore, but rather I start rehabilitation and I let the patient and their knee tell me, can we continue to progress? And the rate of progression through rehab is very similar, if not the same, to what our reconstructed athletes will be asked to achieve, and the goals and criteria that we set out for them. The same is applied to our non-operative management people.
And then if they are hitting all the criteria, that would tell you that they potentially will be copers? Yes. Yeah. Okay.
Yeah, but like I said, you can be a potential coper one day and all of a sudden you get back on the training pitch, and that's a big jump, and that's where I see the greatest amount of people go from being a potential coper to all of a sudden being a non-coper, is when they actually get onto the training environment. So back on the basketball court or back on the soccer field. Because rehabilitation up until then has been fairly static and stationary in the gym. At probably worst case scenario, they've maybe done some jumping and landing on boxes, or they've been training on BOSU balls or wobbly surfaces and they've been able to handle it. But then the training environment's throwing way more chaos at the person. They all of a sudden now have to make decisions. They have to react to unplanned changes of direction and get bumped, and have to sort of think about 2 steps ahead. And that jump in decision-making and cognitive ability can really sort of challenge people. And that's where I see people really go one way or the other. And for some people, that increase in demand is too great for the knee, and their knee gets a bit sore and the knee gets swollen. They start losing trust in their knee. They lose the confidence. And if that happens time and time again, then unfortunately, if this person wants to go back to sport, then unfortunately surgical intervention is probably the best thing for them.
And when would you do this assessment? It would be more towards the return to sport phase, like you mentioned, and then in that case would have the patient to be patient enough to wait for that phase to decide if they're going to eventually...
It's an ongoing process. If we're still talking about that acute phase and rehabilitation phase, and the person hasn't had a reconstruction yet, for me, I sort of think about it in the first 2 to 3 months, especially after ACL injury. I think about that as the quietening down of the knee, so getting the knee really calm, getting the swelling off the knee, getting the range of movement back, restoring the quadricep strength, being the key features of that. And then gradually building the strength up of that injured leg to be within 20% of the other side. Now, that usually takes about 3 months, if we're being honest, for most people to get to that level. And by 3 months, we're now starting to think, okay, can we start running straight lines and seeing, can we develop some fitness again? Can we start working some planned changes of direction again? Can we start hopping and landing and learning how to shock absorb? All that kind of stuff really starts beginning again about 3 months post-injury. And then usually it's a month-by-month situation. if the person's looking good, feeling confident, and they're progressing well, we then start making, after that first month, those changes into creating some more chaos in their training environment and getting them to, effectively get very close to being unrestricted in their training. So they might be playing small-sided games. They might be having to make, complex decisions in a game of sport. They might be playing 1v1 basketball or 2v2, 3v3. And if they're successful in that process, then, we're getting close to then putting them through the return to sport testing battery somewhere between, 5 or 6 months if they're lucky post-injury. So, that's probably the average kind of length of time we're looking for someone that could potentially get back to sport and doing the things they love doing without an ACL reconstruction. But like I said, it's getting through that process, but it's in that last month or two where it is a 50-50. It's literally 50-50. Some people are really successful and they can keep going. And then some people, unfortunately, just can't tolerate that higher level. And they're the ones that, unfortunately, will end up having surgery because they just don't have the same stability. Their knee becomes symptomatic. They might get sore or swollen. Their trust in the knee and the confidence in their knee isn't there. So they end up going down the surgical path.
And in that case, is it not like wasting time doing all the rehab, right? I mean, because I heard you talking before in other podcasts about the phase of pre-op rehab. That's really, they have better outcomes, right? If they have a good pre-op rehab.
Yeah, absolutely.
Anyways, before the surgery, so.
Yeah, and that's probably the hardest. You're 100% right. And preoperative rehab is certainly an important step in the post-operative outcomes. I guess it's just a really hard pill for a lot of people to swallow. After they've injured their ACL, they've gone through 3 to 5 months of rehab, got very close to return back to play, only for their knee to kind of fail at the last hurdle. They often do see that as a failure, and it's our job to really pick up the pieces a bit and really focus on the positives, that they got that far and the quality of their knee rehab is so much better than what the average person will get that hasn't decided to walk down this path. And yes, we've got to start from day one again, and we do have to go back, but their strength return, their knee health, their knee function is going to be so much more better than someone who has just injured their ACL, sat around for 3 or 4 weeks for the surgeon to do their surgery and basically start rehab from 1 month post-op, post-injury. So that's the kind of positive spin and the silver lining I like to really shine a light on, because it is absolutely not a waste of time going through that process. And yes, it sucks that they didn't quite get there and they didn't quite get over that final hurdle, but the quality of their rehab before their surgery is going to be unparalleled, and it's going to set them up way better for post-operative success. And for us, we get some, for physios, we get some really valuable objective measures during that time that we'll go back and reflect on again. So, if we're doing strength testing along the way, which we should be doing regularly, of their quads, of their hamstring, if we're looking at their jump and hop performance, we'll be getting some really valuable numbers there throughout their first, 3 to 6 months of rehab, which we need to then go back and look at, because, when the person's 9 months to 12 months post-op and now knocking on the door again and saying, hey, I want to go back to sport, we need to be thinking, okay, what is this person doing right now? What's the performance of their limbs? And does it actually compare to how they were previously? And we finally have got some good numbers. The amount of people who unfortunately turn up to a physiotherapist's office and clinic who have injured themselves, have had surgery soon after, and we don't know what their baseline is. We don't know what their previous levels of strength, performance numbers are. We're really making blind decisions as we go through rehab, and so it does. For us, it ends up being quite a powerful objective testing process as well.
And I'm just curious to ask you, what would be like a normal time for a patient that chooses for the surgery to do the pre-op rehab?
Yeah, probably on average, whether or not this is right or wrong, on average we probably see somewhere between 4 to 6 weeks of pre-operative rehab before surgery is probably what we see on average. I try to advocate for as close as we can to 3 months, because within 3 months we will get, more often than not, a resolution in knee joint health. The swelling within the knee will really have returned back to baseline levels. Bone bruising, that's always an accompaniment to the ACL injury. They would have mostly settled, if not all of them have settled. The resolution of quad strength in 3 months would be very close in most people. We would have that at least within 10% of the other side. That's what I strongly advocate for. I don't always get that. Sometimes it just comes down to the surgeon's list and that person being available. And it works. Yeah, it depends on what works best for the patient too. They may be coming up to school holidays, or they might be factoring in work leave and these kind of things. So, you have to be respectful of the individual sitting in front of you. You can, jump up and down saying, I need 3 months, and, you get really cranky about that. But, unfortunately, people are people and they've got lives, and they have to sort of do what works out best for them. So that's what I would love for. But I don't always get it.
Yeah. And between the patients that choose to do surgery, the ones that don't, do you see any difference on like recurrence rate of injury and recovery time? There's what I see, but there's also what the literature also shows too. So if we're using really, really good evidence, we've actually got, in young people, our reoccurrence rates of ACL injury sits, so we're talking under 20-year-old athletes. Most of the data comes from the US. Some of the data is coming from here in Australia. And we're seeing re-injury rates as high as 30%. So 1 in 3 under 20-year-old athletes will re-injure their graft, so their surgical limb or their other side, their healthy contralateral limb. We'll see a second ACL injury within 2 years, more often than not, in our young people. Adults in general, if we probably take a wider look at the general population, we're seeing re-injury rates somewhere that hovers between about 5 and 10% as we get older and as the demands go a bit older. Professional athletes, we don't see that many re-injuries of the ACL graft or the second of the other side. Data showing about 5% in a systematic review from a few years ago. In terms of, I guess, the non-operative management, like if you've injured your ACL, you can't sort of re-injure it again, but you definitely can have instability moments, and that's where the Canon trial and some other similar trials, the Compare trial, we've seen where people that have chosen to, transition from a rehabilitation group over to a surgical group sort of exists around about 50%. So people that started off rehab and have either had moments where their knee has got sore or unstable or they've developed symptoms and they've elected to go over to the surgical side, or sometimes in these studies they've actually had a predetermined decision to go off to the surgical side. That sometimes happens too. But yeah, for me, anecdotally, from what I have seen, people that have gone down the non-operative path, I would once again say it's probably about a 50-50. 50% of people will be able to start a return to sport plan without an ACL and keep going and still be able to play sport and do the things they love doing without an ACL and be quite successful. And then the other 50% unfortunately try to go back to sport
and unfortunately have instability and then elect for surgery after that.
And how about the recovery time? Is that any different between the surgery and non-surgery?
It's usually faster for the non-operative and the conservatively managed and the non-operatively managed ACL injured person. If they were to be one of the lucky ones who could go back to sport and go back to their pre-injury levels of sport and activity without a reconstruction, they're much faster recovery times. On average, I would imagine, biological processes and taking the step-by-step processes in a non-professional athlete, I'd argue that process needs to take at least 4 to 6 months before that person's ready to get back on the field again following the rehab processes. We've seen professional athletes, and one case that's well documented is in a Premier League, English Premier League soccer player from over 10 years ago now. He returned back to sport 9 weeks after his injury, ACL injury. 9 weeks playing professional football, including going to the World Cup later that year and including playing a further 2 years at a professional level without an ACL. So that was a significantly faster rehab process than general population could ever do. And I would not be advocating and pushing my non-professional group to aim for that level. And I think to do it right takes at least 4 to 6 months. The cross-bracing protocol, I know where the people have been braced for a period of time and the ACL has, by 3 months, started to heal and recover. And by 3 months, we're starting to get an indication has the ACL tissue rejoined and has started to scar together and form a bridge between the two damaged stumps. That regeneration and healing of tissue takes, at least 6 to 12 months in your own tissue, let alone 2 years in harvest tissue, where it might be your own hamstring or patella tendon. So for that reason being, the recommendation for the cross-bracing protocol participants is still returning back to sport somewhere between 9 and 12 months, plus passing all the return to sport criteria as we'd set out for someone that's had a reconstruction. Now, someone that's had a reconstruction and surgery, the evidence is pretty clear at the moment that 9 months seems to be the absolute bare minimum of time before they should be contemplating returning back to sport. And there's a few papers that indicate that returning back earlier than that 9 month figure in a non-professional setting carries a really significant risk of re-injury within the next 3 to 6 months. So that's kind of where we sit. And for me, I don't push anyone non-professional. So if you're not getting paid to train or getting paid to play a sport, the conversation moves mostly to 12 months post-op, regardless of how things are travelling and how things are going. The 9 month mark is there if people are doing really well, but I kind of, from the outset, we're talking mostly 12 months for most of my everyday patients that walk in the clinic.
And I was curious to ask about the X-bracing protocol that you just mentioned. So during that period, you said, I think 3 months, right? Is the patient exercising and then using the brace for, how does it work? For most of the time? Yeah.
I've got a little bit of experience. I'd certainly, maybe Jane Rooney could come along to your podcast, who's been a really strong researcher and promoter of and actively involved in the research. They've got now over 900 subjects that have gone through the cross-bracing protocol. So Dr. Tom Cross, he's a sports physician here in Australia, which is how and why the bracing protocol is named after his surname. They have developed this system where, they brace the knee, and it's not for everyone. It certainly is now a patient by patient assessment. What initially started out was, let's just put everyone in the initial study. So the initial study was 80 patients, and there was really no, apart from a few exclusion criteria like fracture or repairable bucket handle tears of the meniscus or history of blood clotting and those kind of DVT kind of issues, all types of ACL tears were included in the study. What they found in that first 80 was a clear picture that there was a certain subtype of ACL tear that lended itself to healing better than others. And it seems to be the mid-substance tear where the ACL basically splits in the middle. So rather than detaching from the femoral attachment, it kind of tears right in the middle. And by bracing the knee for a month into 90 degrees, the belief and the thinking is that the two damaged stumps will come closer together. A scar and a bridge will form between the two stumps, and that's where the healing occurs. But the ones that pull off the roof, off the femoral attachment, don't seem to heal as well. So that's kind of where they're moved to the moment. And time since injury too also matters. So the thinking is the sooner the better after ACL injury. So ideally in less than a week would be great, but there's a bit of wiggle room there that if you've injured your ACL within 2 weeks, then that's still acceptable. Even 3 weeks is probably the upper limit of an acceptable time frame between injury and bracing. And this bracing protocol is ever evolving. I've talked to both Tom and Jane about this, but sorry to answer your question, I've completely diverted and regressed there. But the bracing protocol itself, in a nutshell, is a non-weight bearing period for the first 4 weeks, where the person either walks on crutches without their foot touching the ground, or they often have these portable scooters so that they can rest their knee on and they can kind of scoot around. During that period, though, rehabilitation is essential to stop the atrophy and joint contractures and all that kind of stuff, and calf, DVT risk, all these kind of things. So a lot of isometric contractions are being performed within the angles that are limited. So, the braces are really a nice exercise tool in a way, because if you're locked at 90 degrees, you can try to extend your knee into the brace and it blocks you. So you get a really nice, strong isometric contraction. You try to flex the knee into the brace, you get a really strong hamstring isometric contraction. So there's some rehab tips there. They've got bridging, they've got clams, they've got some isometric calf work, they've got ankle pumps. So there's an actual published protocol on the paper, the cross bracing protocol paper that was published in 2023, with everything that's done, and the week by week progresses in the range of movement. But effectively for the first 12 weeks, rehabilitation is guided by the range of movement restriction that the brace is giving you. By 10 weeks post-injury, the person has now got full range of movement back in the brace. Mm-hmm. And then for the next 2 weeks until they get to the 12-week mark, they're in the brace, but they're walking without crutches and all those kind of things. And at week 12, they come out of the brace and rehab kind of looks like what a normal rehab would look like for anyone. So, and look, it's not, we've discovered it's not for everyone, but those that have gone through the process, the results are quite exciting. And my understanding is that there's now approval has been granted for a randomised control trial here in Australia, where they'll compare a surgical group, an ACL reconstructed surgical group, versus a group of participants who have had the cross-bracing protocol, and they'll follow them up for a period of time and compare and contrast the outcomes and really see, what is an appropriate management strategy here. So that's going to be, it'll be another 3 to 5 years until anything is kind of published. So it's a watch this space situation, but for now it's exciting. But it certainly needs to be done through the appropriate channel. So certainly if any of your listeners are here, it's because it can be catastrophic if done. The result could be catastrophic if someone hasn't gone through their due diligence to make sure the person is suitable for the bracing protocol. We've had blood clots develop in people's calves, and because they've been immobilised without any DVT prophylaxis from their doctor, they need to be on blood thinners for a period of time. They need to, first and foremost now, be an appropriate candidate in terms of tear location and time since injury to even justify going into the brace. And then they also need to be followed up regularly. I've seen, unfortunately, a couple of people turn up who have been braced with no medical support at all. And luckily for these people, they hadn't developed a clot and they hadn't sort of developed any nasty side effects. But it can happen. So it certainly needs to be done through the right channels, through the right health professionals, and it's definitely a multidisciplinary team approach if someone's considering this.
Yeah. And I was thinking about the extension. Is it hard to recover the range of motion extension after the brace?
Not as hard as what everyone sort of worries about. I've looked after a few myself, not as many as Jane and the team, who have obviously looked after hundreds and hundreds. But my experience with it is that, and the worst case scenario, I think, with the group of people that they've worked with in the study, is that there was one person or a couple of people in particular who had an extension deficit that lasted maybe 2 weeks. But after some soft tissue manual therapy and some exercise, they were able to get their full knee extension back. My experience working with them is that every time you make that adjustment from 0 to 40 degrees, when they're locked at 90 degrees and the first brace change goes from 60 to 90, that's often a little bit of a uncomfortable week for the person, because to jump 30-degree movement can be a bit jerky and it can feel a bit tight. But usually by the time they turn up a week later, they've found their new range and they've got used to that now, that 30-degree range of movement. And then every week when you're opening up the brace 10 degrees and going that little bit further, yes, that first session it's a bit uncomfortable as their body's now got to try and find a new range of movement. But usually by the end of the week, they've now got comfortable with that new change and that newfound range of movement. So I haven't had any experience with any joint full flexion deformities or flexion deformities post-bracing, and usually within a week that person has now found a greater extension range. So yeah, that's kind of where we see it at the moment.
Mm-hmm. Okay. And between post-op and non-op management, in general terms, what are the big differences?
Not a lot, to be honest, but there are probably two things that sort of spring to mind. One of them is the post-operative management. We're now having to consider not only just the knee joint in itself and the post-operative swelling and pain and range of movement restrictions and the known muscle inhibition from the quadricep muscle group, but we now need to also to respect the harvest site, that the surgeon has taken a piece of tendon off that person and taken it away from its location and now inserted it into the person's knee. So most commonly in the US, we're probably seeing a vast majority of surgeons doing bone, patella tendon, bone harvest tissue, which I love. I've got a surgeon here that I work with quite closely here in Australia, and he routinely does bone patella tendons. And my kind of belief is that if we know the quads are going to take a pretty big hit post-surgery, taking patella tendon probably doesn't add that much more discomfort to the person's journey. But when you take a hamstring harvest, we're now having to kind of focus on two areas to really calm down in those early stages. So we've got to now respect that hamstring harvest. So we walk away with a really weak quad after the ACL reconstruction with the hamstring graft, but then we also walk away with a really weak hamstring in the whole scheme of things as well. Both of those muscle groups are recoverable and we can get them back to their former glory. But that first month to 2 months in particular is certainly a hard challenge to respect the pain, but also respect the ability to load those tissues well. So that's probably the biggest difference that we see. We just have a lot more hamstring surgeries here in Australia, so we definitely need to be a bit more mindful and respectful there. The other probably difference between non-operative management and surgical management is and this is probably, there's not a shred of evidence to say it's right or wrong, but my sort of thinking is the open chain exercises would just need to be modified a little bit for both groups, and that's probably where it differs a little bit. So arguably, if you don't have an ACL, you've injured your ACL and you don't have an ACL, then there's no problem in starting open chain exercises after your injury. But the interesting thing is, right, that we've actually seen people heal without any formal bracing protocol. So we know they can spontaneously heal. The percentage of it happening, it's very debatable. It certainly sits about more than 1%, which is the number that I got quoted when I was at university. Steph Philbay's work from 2022, where they took a look back at the Canon group participants, which the Canon trial is a very famous trial where they compared early reconstruction versus delayed reconstruction over 2, 5, 10 years. And then a third group emerged out of that, being the rehabilitation group, which was the group of people who were still in the delayed reconstruction group effectively, because they were put into that group and 2 years later they're still rehabilitating. 5 years later, they're still rehabilitating. 10 years later, they're still rehabilitating. So that third group emerged. And what they did was they looked at the MRIs of this rehab alone group, the knees of these participants, and they actually found nearly 50% of that group, their ACLs had healed, which probably lends itself to these people doing so well and having great outcomes because their ACL healed. Now, these people didn't have a formal bracing protocol. They didn't do anything special. They injured their knee, they got straight into high-quality rehab, and they just kept on going. And remarkably, over time, their ACL healed. So that kind of, it's an interesting one because you think, okay, if this person doesn't have an ACL, then we can just open chain them. But if there is a chance that this person has an ACL and or if this person's ACL can heal spontaneously, to me, it kind of makes a little bit of sense that maybe we do want to limit that last 30 degrees of open chain knee extension work. So based on our kind of modelling and the studies that have been done on ACL strain modelling, where we know between 0 and 30 degrees off extension, we're seeing strain through the ACL, that some people may consider that to be quite damaging to the healing of the ACL. That's where, for me, if I want to sleep well at night and this person is going through a process of rehabilitation without any formal bracing and they're waiting 3 months, that would be the only thing that I may differ from a post-operative plan. Post-operative plan, it's actually become quite clear that open chain exercises are safe in varying degrees of angles and varying degrees of movement and even varying degrees of load. So even, for someone that's had a full ACL reconstruction, there's been some emerging evidence come out of France in recent years where from week 4 post-operatively, the person is moving through full range, so not a restricted range of knee extension, full range knee extension, so 0 to 90 degrees, with fairly light load. We're talking loads that are around 50% 1RM, so really light stuff and highly repetitious load. But they're able to do that from week 4 through full range, 3 times a week, ongoing from week 4 through to whenever they decide to stop. And 2 things have happened when they looked at the groups that in this study is that by 6 months, there's no lengthening of that graft tissue. So there's no differences between the groups that did the open chain exercise and didn't. But impressively, the quadriceps strength return in that group was so much more stronger than the people who didn't do that open chain exercise, like significantly stronger by 3 months, 6 months, and 12 months when they did the open chain, but there was no negative effects. So that's certainly coming through. We look at ACL published guidelines, and they still recommend, there's about 3 or 4 of them that are current and relevant. They still recommend in the first 12 weeks we stay between 90 and 45, and that's fine. There's no harm in doing that. But there's certainly some emerging evidence that 0 and 90 degrees range of movement is safe and effective when done with the right amount of range and the right amount of load from as early as 4 weeks. So I think, once again, I probably extended that question and went on a few different tangents. But I think if I was to differ my rehab strategies a little bit compared to the two groups, I may just actually modify my open chain in the first 12 weeks for the people who are trying to go conservative and non-operative. And it's, once again, there's not any evidence to support that. It just makes me feel better about myself and makes me sleep better at night time.
You're giving them a chance.
Yeah, that's right. Give them every possible chance, especially if they weren't suitable or weren't appropriate for a bracing protocol.
Yeah. Okay. And now talking about the early post-op rehab, any mistakes that clinicians should avoid?
I think historically we've probably been too lenient or too scared or too careful to load that person in the first 4 weeks to 6 weeks post-op. Often the person is encouraged to, probably rest a little bit more, and there's nothing wrong with that. We need the person and the knee to calm down. We need the pain to really drop down. So there's nothing wrong with icing and compression and elevation and pain relief and any electrical kind of modalities you might use, like electrical stimulation or muscle stimulation, that kind of stuff. But I think definitely in those first 4 to 6 weeks, there are periods of time where we can introduce and implement some really safe and effective early loading. Isometric loading to start with, because it doesn't move any of the harvest tissue. It doesn't overload the knee joint very much. And any maintenance of strength we can hold on to is really key. It's a given that the quadriceps strength will fall off a cliff. It will plummet in the first 3 months post-op. It's our job to really restrict that loss, and if we can minimise that damage, so to speak, then our patients will be in a far better place. So I certainly introduce early isometric knee extensions at 90 degrees, isometric hamstring exercises for my hamstring harvest and hamstring grafts. I introduce early, safe calf loading as well. Calf is often a neglected muscle that really can drift away on you if you're not giving it the attention it needs. And we see that quite a lot, where people have just lost their calf bulk, they've lost their ability to spring and to hop and to run. And that makes that 3 month to 6 month period where they want to jump and hop and run and land, that makes it just much more harder to do. So maintaining their calf strength in that first 4 to 6 weeks is really key. They're probably the biggest mistakes I see. I think there's a lot of passiveness and a lot of too easy, gentle exercising being done in the first 4 to 6 weeks, and we can definitely do something a little bit more tougher love for our patients.
Mm-hmm. And any considerations for exercise selection and progression in the first 6 months post-op?
Yeah, there's a few. I tend to start. I think about my first 3 months in particular of rehab in 3 different phases. So 1 month phases. So my first month, it's all about calming the knee down and being really quiet. The second month, I'm introducing load in a bilateral fashion. So I'm choosing things like a double leg press, a double leg wall sit or a box squat, a double leg hamstring deadlift, double leg calf raise with some resistance, double leg hip thrusters, whatever kind of exercise you choose to employ, make it double leg. That's kind of what I do. Whether or not, once again, that may not be right or wrong, it kind of just makes sense to me. In that next month after that, I apply the same principles, but try to put more emphasis on the operated leg. So, like our leg presses now become single leg presses. Our box squats now all of a sudden become a lunge or a step up. Our kind of deadlifting exercise now becomes an arabesque. Our calf raises now become a single leg calf raise. Our hip thrusters become a single leg hip thruster, and so on and so forth. So that's kind of like how it's very simple, but I keep the loading the same. So we have 3 gym sessions a week roughly, focusing on the legs, and we keep it 2 to 3 sets per exercise, 15 to 20 reps per exercise, keeping it really light and easy, and just establishing a safe, sensible load and laying a really nice foundation for the next 3 months ahead. So because from 3 months through to 6 months, we really need to change our attention and develop some strength and potentially some hypertrophy if the person has got a bit of atrophy in their quads and their hamstrings. So I now shift once again, probably mixing it up between bilateral and single leg training depending on their needs. I'll pick similar exercises, to be honest, but now I'm applying a much heavier load. So we're doing, once again, probably 2 to 3 leg sessions per week. We're now lifting, though, for 3 to 4 sets per exercise, we're lifting somewhere between 8 to 12 repetitions per set. So we're now just increasing that intensity. And we're gradually building that over the next 3 months until we get to that 6-month mark. The difference being in that period of time too, we also need to account for the person starting, jumping, landing, hopping, running, potentially some safe skills in the sport they like to do. So we need to be sort of flexible with our programming and be really monitoring for signs of knee stress. So the first thing the knee will do if it's overwhelmed, it'll swell. And so that regular education and monitoring of knee swelling is really key, particularly as they transition through that month 3 through to month 6, where all of a sudden now they might be jogging again, they may be skipping, they might be doing box jumps, they might be doing some landing, and they're also in the gym. So there's a little bit more going on in that period of time. So that's kind of like how the first 6 months would look like in a nutshell.
Mm-hmm. Mm-hmm. And when do you know it's the right time to begin running and plyometrics?
There's some really nice evidence now to support that decision. It used to be based purely on time. We used to kind of use the 3-month marker as that decision aid, which is a terrible way to be looking at it, using a calendar to help us decide on what we do next. But there's certainly some strong evidence now that says, look, and this is where it's a bit conflicted, right? So we've got some papers that are saying 60% limb symmetry is enough for someone to start running or start a process of running where they'll just often just do a run walk program a few times a week, and they'll do that for a period of time before they build up some tolerance. So there's been a couple of papers that show 60% is enough compared to the other side. 70% is probably the more common number we'll see. But there have been some published guidelines recently from the great research group over in the UAE, ASPETA. So the ASPETA guidelines suggested 80%. And to be honest, that's where I probably align myself with the 80% figure. So looking at, say, the right leg is the operated leg, the left one's a healthy leg. I'd want my right leg to be within 80% of the other side, or no more than a 20% side-to-side difference, whichever way you look at it. That they're the things that I see. That's the number that I tend to see allow people to start running and keep running, and that's probably the big difference. You may get 60% score and be okay to run. You may get 70%, and this is what I see. it's probably a toss of the coin. About 50% of people will start running with 60 to 70% strength. 50% will be able to continue over the next month. The other 50% will get sore after a week or two, and they'll quickly regress. Their knee will get really sore, really swollen, and all of a sudden they've gone backwards a month. What I've seen with the 80% figure is that someone that waits a little bit longer, gets a bit stronger, they're able to start running, and then a month later, almost with great certainty, they'll still be running, and they'll actually be able to transition to a bit more faster running and a bit more unplanned running and a bit more change of direction work. So that's kind of what we see there. And that 80% figure, it really relies mostly on a quadriceps strength score. So either an isokinetic quadriceps score or an isometric strength measure at 90 degrees or 60 degrees, whichever way you choose to look at it. Classically, all research is done via isokinetic testing, so a 60 degree per second isokinetic test, looking to have a limb symmetry score of at least 80%. Would be that. And that's the one that comes back time and time again. Hamstrings probably don't have as much influence on knee health as what the quads do, but that's often the other figure that you want to make sure is within 20% of the other side or an 80% limb symmetry score. That's kind of where we sit.
Okay. And how about return to sport? So what helps you to make that decision?
Yeah, so much like return to running, we've now got better decision aids, thanks largely to, once again, great research groups and some really wonderful studies being done over the last 10 years. Prior to 2016, a lot of the decisions to return to sport was basically down to time. And usually there was an arbitrary time value of 6 months, 9 months or 12 months. And once again, we know the calendar is not a great system to determine readiness to return back to sport. So time certainly weighs into the discussion still. And as I said before, 9 months post-op seems to be the more consistent figure in if we just use time. But we now know we need to have that bare minimum biological healing time. So we need the graft to biologically mature enough. And 9 months seems to be an appropriate time for the graft maturity to set in. So we need that 9 month figure at least, plus meeting a list of criteria. And this is where the research is really messy. It's incredibly messy and dirty. In terms of testing is what I'm referring to. So there's lots of different studies that use different testing batteries and whatnot. The thing that probably comes through the most consistent is quadricep strength. Once again, looking to get at least 90% quadricep strength via isokinetic means or isometric means. Hamstrings, once again, 90% being that cutoff score. Hop testing and functional testing is often the really strong complement to the process. Now, classically, we would use a horizontal hop test battery consisting of 4 hops. So a single leg hop for distance, a triple hop for distance, a triple crossover, or a 6 metre timed hop test. And we would test those four hops. We would compare the ACL leg to the uninjured leg and looking to get at 90% score or more. Lately, though, in the last, once again, 4 or 5 years, the Aspetar group have looked at functional testing, and in particular, the vertical jump testing seems to be a really important test to determine readiness and return of function. They looked at actually a single leg hop for distance and found that in their ACL reconstruction group, an ACL reconstructed athletes could hop on one leg, so their ACL leg could hop to about 97% of the distance of their healthy leg in a horizontal fashion. So they are getting really good horizontal hop test scores. However, on average, that same person, if they were to do a single leg vertical jump or a single leg drop jump where they dropped off a box and bounced up immediately off the force plates, their scores plummeted to about 80%. So there was a significant drop in the ability of that person's knee function. So single leg vertical testing seems to be a really important measure, because the horizontal hop testing can hide some important knee features for the person to shock absorb, change direction. A vertical component places more work on the knee. Horizontally, you can cheat through the hip, you can cheat through the trunk, you can basically get to the same distance, but you can use lots of different strategies to get there and land there. Vertically, you've got all that work being driven by the knee. And if your knee strength is not up to task, then it'll show on that vertical jump testing. So that's probably coming through the literature as an important test to include in your battery of testing. Now, outside of functional testing, like hop tests and strength tests, it's also important to look at psychological testing as well. So patient-reported questionnaires is a really important part of the process as well. The ACL RSI questionnaire is really important. So we know that the psychological readiness of the person needs to be looked at. There's been some papers there that show certain scores are linked to higher risk of re-injury or a lower risk of re-injury, depending on which way you look at it. Certainly the higher the score, the better. So marked from 0 to 100. There's one paper that showed a cutoff of about 77 was the determinant between those that were to go on to have a second ACL injury over 2 years, or those that were their knee was able to survive the next 2 years. So a score above 77 is certainly a score to be aiming for, and it's deemed to be a bit safer. TSK11 questionnaire is also a really good one to use. It's a measure of kinesiophobia. It's the reverse though, so higher scores on that measure are associated with worse outcomes and worse kinesiophobia and knee confidence. So a score over 19, so scores greater than 19 on that, are associated with a much, much more risk of a second ACL injury occurring over the next 2 years as well. Then we've got other measures like the IKDC questionnaire, the COOS questionnaire. We need to be taking broader appreciation of the person, not just looking purely at their quads and their hamstrings. So making sure that some psychological and patient-reported questionnaires are also included in the discussion.
And I was reading the ACL Rehab Guide, right?
Cool.
So if people are confused about all these questionnaires, I thought it was very helpful that you had that on the guide, the phase 4 return to sport criteria. So everything is really detailed, that if people are confused or too many questionnaires, you have everything described and show and how to classify and the points. So that's very helpful.
Yeah, that was the whole point of putting the guide together, to make it really easy. I'm working on version 3.0 at the moment, so hopefully later this year we'll have an updated guide. The one that you've got and the one everyone's got at the moment, was published in 2018. So it's been a number of years, and a lot in the research world has changed. So it definitely needs an upgrade, and hopefully later on this year we'll have a new one for everyone to read and enjoy and have in their clinic.
That's exciting. And what I really like about the guide is that it's outcome based, right? So it's not time based, as you mentioned a few times, that you shouldn't be guiding ourselves based on time. But then it's really cool that you have all these criteria that you can base yourself to go to the next phase.
Yep, correct. Yep, that's right.
And before we transition to your social media, I know you're almost out of time. I just wanted to ask a few quick questions about social media.
Yeah,
Anything
sure.
else about ACL that we forgot, or do you think it's important?
No, I don't think so. I think we've covered off the vast majority of things that need to be talked about. We snuck some open chain exercise stuff in there, which is always a good one to talk about. And we talked about the early loading, and the cross bracing protocol. And no, that was a really meaty discussion. Yeah. So hopefully people have got some really useful information out of that.
Absolutely, it was. And so you built a strong social media presence, right? So what inspired you to start that, and how that changed your career, influenced your career?
It's a good question. I think what inspired me to start with was I in 2016 I'd kind of found myself. I'd moved to Melbourne. My wife and I had moved to Melbourne, and I found myself in a role where if I wasn't seeing a patient, I wasn't getting paid. Whereas previously, for my first 5 or 6 years of my career, I was getting paid an hourly wage. I was an employee, and it kind of, if I didn't see a patient, it was kind of no. To me personally, it wasn't a detriment to me. I'd still be able to sort of do things and still learn and go and shadow or do things like that. But when you work as a subcontractor, where I was, every hour that you're not seeing someone is kind of your time, your money. So I was studying. I started studying my masters in that time as well, and so I sort of found that I could really maximise that study time, and in that time I also discovered a few interesting research articles about knowledge translation and how we kind of have such a lag between a paper being published and it being accepted clinically. The number that I read back then was that it was about a 17-year gap between a paper being published and to all of a sudden now being practiced universally, like a long time. And I read that and I fell off my seat, and I was like, I don't have a huge following back then, but I've got the ability to make sense of the research. I had access to an open library at university. I was doing study. I was reading great papers and having to write university papers, and I had some downtime. So it kind of met right in the middle where I thought, maybe I could be one of these people that writes blogs and puts them out there on the internet for people to read, because I've been following a few people, and I thought, why can't that be me? So I just started writing some blogs, and to be honest, to start with, I was actually really scared of writing about ACLs, and I felt like there were some people that were much, much more smarter than me when it came, and arguably they are, and they still are smarter than me when it comes to ACLs. But I kind of stayed in a really vanilla lane of, talking about the stretching or, injury prevention programs, or just some really safe sort of topics to cover. And then I sort of flirted with a bit of ACL stuff every now and again. I started social media, all the platforms, the YouTubes, and first started doing it mostly on LinkedIn, but then drifted over to Instagram and Facebook and Twitter and all the other platforms. And that's kind of how it started. I just sort of, I found there was a really strong. I had the luxury of having great access to education, and I felt as a clinician I had a job to do to help break down these paywalls that a lot of these great papers get hidden behind. And if I could do it in a manner that made it really easy for people to understand, both clinicians and also the general population, then I felt like I was going to be improving the outcomes of our patient care in the long run. So that's how it all started, and that's what the passion and drive was.
That's good. And you just use that time and try to share something helpful for other clinicians, and then it was growing organically. People start enjoying your content, and that's how it
I think so. I hope they still do. I've probably become a bit boring. I'm not as exciting or creative as some of the great people out there at the moment that are really creative and putting together some incredible content on Instagram Reels and TikTok. But I keep it pretty sensible and pretty simple. I don't have the time to be really creative.
That takes a lot of time, creating all those reels and.
I don't have the time for that, but I'll definitely have time still to write and to do that, and I'll just still do that. So it's been fun. I've really enjoyed it to be able to contribute to the Melbourne ACL guide, and then to be able to produce some online content and produce an online education platform, through Learn.Physio, to be able to sort of assist and research ACL researchers worldwide and assist in their publications, and to be able to help co-author some papers and attend conferences. Like it's been great, and to be able to really take a deep dive into a very really focused area of the human body. It's been great. I've really enjoyed it. I love talking about knees and ACLs, and I love seeing them every day. Every ACL that walks in the clinics are different. It's got a different head, different personality attached to the knee. That person has got different goals, different dreams, different jobs, different families. Everything's different. It may be an ACL, but it's a different person. If someone walks in with a shoulder or a back, I'm not as good, and I'll be passing that person off as quickly as I can to someone else. But the knees I love seeing. So, and that's all been helped by by the social media stuff. It's definitely helped.
And I imagine like your platform, the Learn.Physio, it looks great, all those master classes, all these great clinicians. So I assume your social media also help the platform, right? Yeah,
definitely. In the early stages when we set up all our Learn.Physio accounts, it certainly helped that I was involved in a lot of the master classes early. That helped sort of people, bring their attention over to Learn.Physio. I don't have to sort of do so much of that anymore. I think Learn.Physio has got a really strong following now, and it kind of looks after itself with its own social media and mailing and newsletters and all the great content and courses we get people to do for us now, which is great. So it's been a joy to be able to finally put regular content out there for physios worldwide. There was a time there early on where we just couldn't film the amount of stuff that we wanted to due to COVID or through lots of different reasons. But in the last 2 years in particular, we've finally been able to consistently release new content every month, which has been great. It's been great for to be able to do that and to really keep clinicians actively involved in learning and learning from our website. So it's been great.
And I was going to ask about the Learn.Physio. So how did you decide to start that platform?
It's an interesting one because we Randall and I, on the back of the Melbourne ACL Rehab Guide, when we first published it, we wanted to put a video together to kind of bring a visual, bring the guide to life, so to speak, to actually put some exercises behind the guide or to give some kind of rationale in a spoken format in a visual way to complement the guide. So we put together a 2-hour masterclass that supported the guide. And at that stage, we didn't really have a platform to put it on. And I'd, prior to that, had recorded a few presentations. I'd sort of given some public presentations about ACL injuries. So I kind of got the screen recording and the Zoom head up in the corner, and it was on a dodgy microphone and a dodgy laptop, but I had this PowerPoint slides sliding across, and I'd found this website called Learn.Physio, funnily enough, and it was a marketplace. Originally, it was run by someone else, and it was a marketplace for physiotherapists to put their content. So I produced these really crappy PowerPoint-driven videos and put them online, and I put them on this marketplace called Learn.Physio. And so when Randall and I published this really, really slick 3-camera audio production, like it was a beautiful looking video, we didn't really have anywhere to put it. So I said, well, I use this thing called Learn.Physio. We should put it up there. And so we put the video up there, and I took my old crappy ones down, and we kind of just let the ACL masterclass do its thing. And it was up there for maybe 6 months or so. And I got talking to somehow I got talking to the owner of that website at the time. He was an Australian guy, and I don't know how the conversation came up, but he said, do you want the platform? do you want the Learn.Physio platform? And I said, like for free. And he said, yeah, I've sort of, I just don't have time for it. I've kind of got other interests now, and it's yours if you want it. You're the only one that's got a course up there that's making money off it, and it's only thing value up there. There's all this other crap stuff that just don't add any value, and I'm just going to walk away from it. It's yours if you want it. So yeah, Randall and I just accepted it. We're like, yep, we'll take it. Thanks very much. And that's how it started. And, we've now changed the platform itself. Obviously, it looks a lot better than what it used to. It's on a different website host. It's got a lot more different features and a lot more courses. But, yeah, that's how Learn.Physio was born back in, I think, about 2017, 2018.
That's awesome. Very good. And any advice for clinicians that wanted to build their own professional presence online?
Yeah, the only advice really is just to start. I don't have anything really other than that. Often people are held back by fear, and I've certainly been many stages of my career, struck down by imposter syndrome and not feeling like I shouldn't be the voice to advocate for this, or I shouldn't be the person that's talking about this. There are much more smarter, more clever people in the world than me doing this. And they probably are out there doing their thing as well. But, like if you've got something to say and hand on heart, what you're saying is going to be helpful to improve your patients' outcomes and the wider health of the general population, then, you just have to start. And ultimately, what sort of, I guess, holds you back, and maybe some of the imposter syndrome elements of you not starting. I always think about, if you have learnt something in great detail, if you've researched a topic, or you've taken a deep dive in a particular area of the human body, or quite a lot about hamstring strains, or you manage a lot of calf strains, or a lot of shoulders, or a lot of neck complaints, you'd know a lot more about that than most people in the room. And so that in itself is putting you above the pack. So if you've got something really valuable to say, then I firmly believe you should be able to say it. And I think it's important to sort of add to the fact that if you are going to do this, it certainly helps build some level of trust. And if you are going to sort of make some, you're going to do posts, or you're going to do social media posts, or you're going to write blogs, and developing that trust sort of comes with making sure that, you provide some really good references for what you say. Not just making bold statements without anything to justify. That's certainly been a cornerstone to my social media over the years, is that, anything that I say has certainly got some evidence backing to it. There'll be some posts that I put out there that show me do a lunge or a terminal knee extension or something like that, and I'm just describing an exercise on how it can help someone's rehab. But if I'm making bold claims about open chain exercises, or if I'm saying that plyometrics are more effective than not doing plyometrics, it's certainly evidence backed as well. So if you are going to take that leap and do something to share the information and build your own social media presence, I'd certainly make sure you've got the research to back you up, to build that trust with your followers.
Yeah. And if you don't share, nobody's going to see it. So you got to start
That's
sharing.
Right. Yeah, got to start.
Yeah. Mick, thank you so much for your time. I know we are out
Pleasure.
of time here. If people want to learn more about you, how they can find you?
Yeah, sure. Well, thanks very much, Mariana, for the opportunity to talk. It's been great. They can find me. I've got a website, www.mickhughes.physio. You can find my contact details there. You can find me on Instagram, Facebook, LinkedIn, Twitter, or X these days, Threads. I do have a TikTok account, but I kind of don't open it up much anymore. It's too young for me. And so my handles are all mickhughes.physio for all those things, and YouTube as well. And of course, you can find me and ask me questions via our Learn.Physio platform, which is www.learn.physio. Learn.Physio. So, yeah, find me in one of those many places.
And you can get also the Melbourne ACL Rehab Guide online for people that are interested in
absolutely
checking that
get
out.
it. You can get it, download it for free. It's absolutely, and even the new version when it comes out, it will also be free. So watch this space.
Awesome. Thank you so much, Mick. I appreciate your time and all the knowledge that you share with us.
Pleasure. Thank you.
That's all for today's episode of PT Pro Talk. We hope you enjoyed this discussion. Be sure to follow us wherever you listen to podcasts so you'll be notified when we release future episodes. You can also join our email list at ptprotalk.com to receive updates and access new episodes. If you have ever gotten value from the show, please take a moment to leave us a 5-star review. It always makes my day and it really helps us out. If you have any guests or topics you'd like to see on the show, let us know by answering a quick survey. You can find the link in the show notes, along with more information about our guests, resources, website, and social media. Thanks again for listening, and until next time.